welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP-EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Today we have Megan Ott, who is a PGY2 emergency medicine resident at Nebraska Medicine. Today she will be presenting a journal club on efficiency and safety of high-dose, undiluted intravenous push levetiracetam loading doses compared to the intravenous infusion in seizing patients, a retrospective cohort study. Thank you.
Jump right in. And before I start, I would like to mention that I do not have any financial disclosures to make. And as we move forward into discussing the role of IV push levetiracetam in patients with seizures. Starting with some epidemiology, so between 50,000 to 150,000 Americans each year experience some form of status epilepticus. Mortality is estimated at less than 3% in children. However, it can be up to 30% in our adult population. And then a significant portion of children, around 38%, and adults, around 50%, with status epilepticus have a known history of epilepsy, which I feel like it's a good population that we do see in the emergency department. And then looking at some of the definitions, so the 2012 Neurocritical Care Society guidelines define status epilepticus as a seizure with 5 minutes or more of continuous clinical and or electrographic seizure activity, or recurrent seizure activity without recovery between the seizures. Whereas the 2016 American Epilepsy Society guidelines define status epilepticus as 30 minutes of either 1, continuous seizure activity, or 2 or more sequential seizures without full recovery of consciousness between the seizures. As far as some etiology or things that provoke seizures, there's some acute factors that we can consider, like infections, metabolic imbalances, trauma, and then toxins or drug withdrawal, compared to some more chronic conditions we think of, like epilepsy syndromes, particularly those with poor seizure control, brain tumors, and then even neurodegenerative diseases. I would like us to appreciate the saying that I'm sure many of us are familiar with, time is brain, and this is especially important in status epilepticus because delayed treatment often leads to refractory and difficult to control seizures. Furthermore, seizures of greater than 5 minutes are unlikely to end spontaneously on their own, and then seizures greater than 30 minutes often lead to significant neuron damage and very poor functional outcomes for patients. And there are numerous clinical studies that demonstrate a relationship between seizure duration and mortality, which makes seizure termination an extremely important clinical goal for us in this patient population. I know many of us are probably familiar with the 2016 American Epilepsy Society guidelines that have a nice algorithm we follow in different phases. I have it simplified here on the next slide. So in those first 0 to 5 minutes, we want to stabilize, assess, and attempt IV access for our patients. If the seizure continues beyond there, in those 5 to 20 minutes of status epilepticus, guidelines recommend a benzodiazepine. And then in the 20 to 40 minutes is where the guidelines do not specify a preferred agent. However, they list fosphenytoin, valproic acid, and levetiracetam as options. And just pointing this out for today's presentation, as levetiracetam is the drug that we're going to focus on. Therapy beyond there, in those 40 to 60 minutes, there is really no clear evidence and guidance, but a lot of times infusions, ketamine, phenobarb are often used for refractory beyond those 40 to 60 minutes. So let's talk a little bit more about levetiracetam as an overview. So the precise mechanism is unknown. However, it is thought to be inhibition of calcium channels, along with facilitation of GABAergic inhibitory transmission, and reduction of delayed potassium currents, along with SP2A antagonism. The dosing for status epilepticus with this medication is 1 to 3 grams as a single dose at a rate of 2 to 5 mg per kg per minute, or 40 to 60 mg per kg as a single dose. And then there's a maximum single dose of 4.5 grams. As far as administration, the manufacturer recommends administration as an IV infusion over 15 minutes. And then some adverse effects. So the most common ones are going to be vomiting, psychiatric abnormalities, CNS depression such as ataxia or drowsiness, and then more rare but are possible are our hypersensitivity reactions in about less than 10% of the population. And then quickly, I'm sure many of us are familiar, but I do think it's important to note IV push dose therapy refers to the administration of high doses of anti-epileptic drugs over a short period, so typically within minutes. IV push allows for rapid onset of a drug. Theoretically, it can result in effective seizure control. And lastly, clinical convenience both for nurses, pharmacists, providers, and the patient. And I would like to highlight two studies. The first one we're going to look at for background literature was by Shim and colleagues, most recently in 2024, that looked at IV push versus IV piggyback levetiracetam. Their objective was to observe the safety of administrations in patients receiving levetiracetam IV push compared to IV piggyback in the acute care setting. This was a multi-center observational retrospective cohort study that included just over 1,000 adult patients who received the medication pre and post implementation of their IV push protocol. And the patients in this study received Keppra or levetiracetam for any indication. Their primary outcome was time to order verification to administration of urgent first-time doses. And their secondary outcomes were time to administration of loading doses, infusion site reactions, and cost savings. And what these authors found was that IV push reduced time to administration significantly, so 61 minutes versus 47 minutes in the IV push group. They found similar rates of infusion site reactions, but it was low overall, so only about 6 versus 5 patients had experienced infusion site reactions. And they estimated a pretty major cost savings between $76,000 and $11,000 for IV push. One of their major limitations were that majority, so 75% of those administrations were lower doses, so between 500 to 1,000 milligrams, which made it difficult to apply this study towards patients receiving those loading doses for status epilepticus. So we move forward a short time later, Martinez and colleagues published their study, which was evaluating the safety of undiluted IV push loading doses of levetiracetam greater than 2,500 milligrams to really fill that gap in the literature. Their design was similar, single center observational retrospective cohort analysis. The population was a little smaller, so just over 500 adult patients who received a loading dose for status epilepticus specifically. And their outcomes were any documentation of pain, erythema, extravasation, IV line replacements, or other adverse effects related to IV push levetiracetam. Overall, they only found 2 patients of the 518 that had IV line replacements that were potentially related to levetiracetam, although it was hard to determine that given the retrospective nature. They found no documented adverse effects in the patient's charts. All doses were greater than 2,500 milligrams, with about 50% of those administrations being on the higher side, so 4,000 to 4,500 milligrams. And lastly, the major limitation here is they did not assess efficiency, incidence of rescue medications, ICU and admissions, intubations, really those patient-centered outcomes that we're looking for. So comparing these two studies next to each other, the clinical application of the first study, levetiracetam up to 1,000 milligrams administered via IV push may be considered a safe, more logistically and economically efficient method of administration in an acute care setting. And then the study by Martinez, the clinical application is that levetiracetam up to 4,500 milligrams appears to be safe and tolerable for loading doses in the acute care setting, although this was not compared to IV push. So this is where we'll introduce our study for today. Before we do that, I do want to take a minute to bring up a discussion point. We can talk about this a little bit towards the end of the presentation, but for now, a simple yes or no in the Zoom chat would be great, just to kind of gauge the audience of, does your institution administer levetiracetam via IV push for seizures? It looks like a few more yeses than nos, which will be good since we have kind of a split audience to see how everyone applies this at their institution. So the study for today is efficiency and safety of high-dose undiluted IV push levetiracetam loading doses compared to IV infusion in seizing patients. This is a retrospective cohort study by Coons and colleagues in 2024. The objective of their study was to investigate the efficiency and safety of rapid IV push levetiracetam compared to IV piggyback in patients with acute or suspected seizures. The design of their study was a sequential, non-randomized, retrospective cohort study. This was a single-center study that took place at Massachusetts General Hospital, and it was conducted from January of 2022 to October of 2023. Their population included adult patients who received IV loading doses of levetiracetam, defined as doses of greater than 2,000 milligrams or greater than or equal to 20 mg per kg for acute or suspected seizures. And they excluded any doses that were administered for indications other than acute or suspected seizures or initial doses that were not loading doses. So this was things such as maintenance doses that were on that higher end of greater than 2,000 milligrams. As far as their outcomes, their primary outcome was time to administration between IV push and IV piggyback levetiracetam. This was when the 15-minute infusion started or the IV push was given. And they defined this as the time between pharmacist verification and nursing administration. And they chose pharmacist verification as the original time because IV compounding and or dispensing was only possible after verification had occurred. Some secondary outcomes they looked at were cardiovascular, were defined as occurrence of hypotension, so systolic blood pressure less than 100 within 2 hours of administration. They looked at sedation adverse effects, so documented change in RASS or GCS of less than 2 or greater from pre-administration baseline within 4 hours after administration. They chose this wider time interval to account for less frequent documentation of the scores. And then they looked at injection or infusion adverse effects. So this was nursing documented line infiltrations, extravasation or pain upon injection, redness noted around the IV site, and nursing notes and clinical documentation were reviewed for those events. They also collected rescue agent administration in between levetiracetam order placement and administration. These were defined as IV or IM benzodiazepines or IV anti-seizure medications. They collected intubation after levetiracetam order placement and administration, the need for ICU admission, length of stay, and the reason for delay if doses ordered as stat were administered over 60 minutes after verification. As far as statistical analysis, baseline characteristics were summarized as percent for categorical data and median with IQR or with standard deviation for continuous variables. Fisher's exact tests or chi-squared were used for categorical data, and student t-test or Wilcoxon rank sum were used for continuous. A survival analysis was conducted for time to event analysis, and multivariable logistic regression was used for exploratory associations between treatment characteristics and ICU admissions. Looking at our patient cohort, so 266 patients were assessed or screened for inclusion. 20 of those patients were excluded for prophylaxis, having home medications, not having a clinical seizure, or age less than 18 years, which left us with 246 total patients. 130 of those patients were categorized into the IV piggyback group versus 116 patients in the IV push cohort. Overall, the patient population was well balanced with a few notable differences. So the average age was around 55 years old. About half the population was male. The average weight was around 80 kilograms. About 28% of the patients in the IV push group were loaded for status epilepticus versus 35% in the IV piggyback group. As far as location, more patients received IV push than IV piggyback while in the emergency department, and that was statistically significant. And this was flipped, or the opposite, for ICU. So 19% in the IV push group versus 27% in the IV piggyback. And the remainder of the total patients that were not in the ED or the ICU received levetiracetam on the medical floors. As far as neurologic comorbidities, around 17 to 18% had an ischemic stroke. Majority of the patients had a seizure disorder, and there was a statistical difference with more patients having a substance or mood disorder in the IV piggyback group compared to the IV push. Looking at the results from the primary outcome found that the time from administration was statistically shorter in the IV push group. So this was 12 minutes in the IV push versus 38 minutes in the IV piggyback with a p-value of less than 0.001. They also looked at orders that were placed as stat, which was even across both groups. However, they found a much higher incidence of delays in stat administration in the IV piggyback group. So 37% in the IV piggyback versus only 11% in the IV push group. The average dose was similar in both groups, being around 3,000, 3,500 milligrams, and a weight-based dose of being 41 mg per kg in both groups. So what they concluded from the primary outcome is that IV push reaches the patient faster and results in less medication delays. Looking at some secondary outcomes, any adverse event, so you can see here there was a statistically higher incidence of adverse effects happening in the IV piggyback group compared to the IV push group. They also looked at if antipsychotics were administered within 24 hours of the loading dose, which was similar among both groups. They assessed intubation after loading doses, which was about even across both groups. The incidence of rescue medications being needed was higher in the IV piggyback group, but not statistically significant, and the incidence of ICU admission was numerically higher but not statistically different in the IV piggyback group. So big takeaway from the secondary outcomes was that there was no statistical differences, although numerically higher incidence of adverse effects, rescue medications, and ICU admissions in the IV piggyback cohort. I did like that the authors broke down a status epilepticus subgroup in this population. So this was about 32 patients in the IV push group versus 46 patients in the IV piggyback group as a total. And what they found was similar to the last analysis, but slightly different. So time to administration, so the primary outcome, again here in this subgroup, was statistically significant with a quicker time to administration in the IV push group, so 12 minutes versus 44 minutes. That's a big difference when we're talking about active seizures. The order being placed stat, slightly different between the two groups, so higher in the IV piggyback group, but the delay in stat administration was about 15.7% in the IV push group versus 50% in the IV piggyback group. So half of the patients in the IV piggyback group had a delay in a stat administration. They looked at adverse effects in these two groups, and they found a statistically higher amount in the IV piggyback, and this was primarily driven by the incidence of sedation. So about 20% of the patients in the IV piggyback group versus 0 in the IV push. ICU admission was also a pretty big difference, about 71% versus 46, so higher incidence of ICU admission in the IV piggyback group, along with intubation, so 65% in the IV piggyback versus 33% in IV push. So what we take away from this subgroup is that fewer patients in status epilepticus required ICU admission, intubation, and had lower rates of adverse events after receiving IV push loading doses versus an IV piggyback loading dose. And these outcomes remained consistent after the authors adjust for age, history of epilepsy, the dose that was administered, and their STES, so their status epilepticus severity score. And what the authors concluded was that rapid IV levetiracetam reduced time to administration and was associated with similar rates of adverse effects compared to IV piggyback. They also concluded that doses up to 4,500 milligrams of IV push are safe and well tolerated, and that loading doses given via IV push may be associated with lower ICU admission in patients with status epilepticus and in patients loaded in the emergency department. They did leave off with saying that future studies should evaluate the ECG effects of administration methods and prospectively evaluate clinical effectiveness of IV push versus IV piggyback. And this leads us into our discussion. So some strengths to point out: this is the largest study to date that compares the efficiency and safety of IV push levetiracetam loading doses to IV piggyback. So this really filled that gap in literature that we were missing. Over 30% of the patients in this study had received a loading dose for status epilepticus, which was nice to see that subgroup analysis. And they adjusted for age, history of epilepsy, the dose that was administered, and their severity score, which was nice to look at as well. Some limitations to note: obviously, retrospective data collection. We're all aware of the bias or confounding that can introduce. They also did not account for potentially confounding medications and or medical events at the time of administration, which I think it would have been a little bit nicer to see a little bit more of those things. They did not evaluate the rates of seizure response. It sounded like maybe they were hoping to initially, but they just found that it was really inconsistent documentation. and hard to find the exact times, which is understandable in a retrospective study. And lastly, they utilize some semi-objective outcomes, such as like agitation in their secondary outcomes. And then the summary and thoughts I'd like to leave you all with today. So I think that this article provides great supporting literature for the safety and efficiency of IV push levetiracetam. Like the author said, the next key steps would be to evaluate the effectiveness with a randomized control trial to help support the literature a little bit more. I think it's important to appreciate the well-observed relationship. So we know that prompt seizure management improves functional outcomes and reduces mortality for patients with status epilepticus. And then from there, we can kind of draw a conclusion that IV push levetiracetam increases medication efficiency, which would hopefully include prompt seizure management for our patients, so better outcomes for them. And lastly, what does IV push look like logistically? Is this nursing, pharmacist driven? Does a provider need to be at bedside? There's a lot of logistical questions that come up when talking about this. The authors reported using undiluted, so the 100 milligrams per 1 ml IV push over 2 to 5 minutes, and that doses greater than 1,500 milligrams were drawn into multiple syringes to comply with compounding regulations. So that would be anywhere from like 2 to 3 syringes per loading dose, depending on the patient weight. And lastly, I'd like to acknowledge and thank my preceptor, Dr. Hannah Stonewall, for her help and guidance in this presentation. And I would love to open it up for questions or thoughts. If anyone would like to share what they do at their institution or any challenges that they've ran into or solutions that they found, that would be great to hear.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.